Hi, good night, everyone. I am Sherry Sargent, and tonight I'll be doing the first part of the two-part lecture series on melanocytic tumors, CNS germ cell tumors, and part two would comprise of the hematolymphoid tumors involving the CNS. Starting off with melanocytic tumors, these are rare and can be diffuse or localized CNS tumors that presumably originate from the leptomeningeal melanocytes. They can be circumscribed or diffuse. The circumscribed melanocytic tumors are the meningeal melanocytomas, meningeal melanomas, and diffuse melanocytic tumors can comprise of meningeal melanocytosis and meningeal melanomatosis. These primary CNS lesions may be distinguished from other pigmented CNS neoplasms, for example, malignant melanocytic nerve sheath tumors, using molecular analysis and methylation profiling. So starting off with diffuse meningeal melanocytic neoplasms, these are rare as mentioned, primary CNS neoplasms that involve the leptomeninges and they spread diffusely throughout the subarachnoid space, sometimes with focal or multifocal nodularity and frequent invasion of the vertebrobin or perivascular spaces. There's a predilection for the temporal lobes, cerebellum, pons, medulla, and the spinal cord, and distinguishing these primary tumors from metastases originating outside of the CNS is critical for treatment decisions and prognostication, and often requires molecular testing in addition to microscopic histology. These tumors, they frequently occur in the setting of neurocutaneous melanosis, which is a rare neurocutaneous disorder, and the symptoms may be due to hydrocephalus or from dysfunction of invaded brain. Other associations include arachnoid cysts, syringomyelia, other brain tumors such as astrocytomas or epinemomas, and other structural conditions such as Chiari malformations. Symptoms progress rapidly with when malignant transformation occurs, and on MRI findings, they vary with the amount of melanin content, and these tumors may be isodense or hyperintense on T1 weighted imaging and hypodense on T2 weighted imaging. There are case reports of these tumors as well spreading into the peritoneal compartment, especially when VP shunts are used to treat hydrocephalus. So, meningeal melanocytosis, it's a diffuse or multifocal proliferation of cytologically bland melanocytic cells, and they may spread into the perivascular spaces without invasion of the brain. Symptoms related will develop in 10 to 15% of patients with large congenital cutaneous melanocytic nevi, and they may be asymptomatic. Prognosis is poor once the symptoms manifest. With meningeal melanomatosis, malignant histology distinguishes these tumors from meningeal melanocytosis, and CNS invasion is a common finding, usually aggressive, with poor prognosis. So the diagnostic criteria for diffuse meningeal melanocytic neoplasms essential would be diffuse or multifocal primary meningeal melanocytic neoplasm, and for meningeal melanocytosis, the absence of CNS parenchymal invasion, absence of marked cytological atypia, absence of mitotic activity, and absence of necrosis. For meningeal melanomatosis, invasion of the CNS parenchyma and/or marked cytological atypia or mitotic activity and/or necrosis. What is desirable would be in children with meningeal melanocytosis or melanomatosis is often the NRAS mutant and rarely the BRAF mutant, which is more aggressive. So circumscribed meningeal melanocytic neoplasms, these tumors, they arise from the leptomeningeal melanocytes and they vary from well-differentiated neoplasms to aggressive malignancies. An intermediate grade between these two exhibits bland cytology but increased mitotic activity on invasion of the parenchyma. The diagnostic criteria for circumscribed meningeal melanocytic neoplasms essential would be circumscribed or localized primary melanocytic neoplasm in the meninges, and for melanocytomas, limited cytological atypia with almost no mitosis, no necrosis, and in cases of the valuable CNS parenchyma, no CNS invasion. For intermediate grade melanocytomas, a mitotic count of 0.5 to 1.5 mitoses per millimeter squared and or CNS invasion, but limited cytological atypia with no necrosis. For melanomas, mitotic counts of greater than 1.5 mitoses per millimeter squared and or necrosis are often accompanied by marked cytological atypia. Demonstration of the following molecular markers, GNAQ, etc., mutations, corroborates the CNS origin of the neoplasm, especially after exclusion of uveal or blue nevus-like melanoma, and this makes it desirable features. Additional molecular markers indicates aggressive behaviors, and these would include the BAP1 and the SF3B1 molecular markers. For meningeal melanocytomas, these are well-developed, solid, non-infiltrating melanocytic tumors that arise from the leptomeninges, and they are characterized by epithelioid fusiform polyhedral or spindled melanocytes with no evidence of anaplasia, necrosis, or increased mitosis. Rare reports of malignant transformation, and it comprises of 0.06 to 0.1% of brain tumors with an estimated incidence of 1 per 10 million. Most commonly, it's found in the cervical or the thoracic spine, and less commonly, they originate in the leptomeninges in the posterior fossa or supratentorial intracranial compartment. A handful of these patients with a nevus of Ota, which is also known as an oculodermal melanocytosis, which results from incomplete migration of melanocytes from the neural crest to the epidermis, have concurrent meningeal melanocytomas. With meningeal melanomas, these are primary solitary malignant neoplasms that arise from the leptomeningeal melanocytes, and they are characterized by aggressive growth patterns. Histologically, they are similar to melanomas occurring elsewhere, and they are compared to melanocytomas. These are more pleomorphic, anaplastic, mitotically active, and often invade CNS tissue and may demonstrate necrosis. They may spread through the CSF pathways. Occasional systemic metastases outside of the CNS also occur, and the incidence is the incidence of 0.5 per 10 million. The peak age of this tumor is in the fourth decade with a mean age of 43 years, and compared to the seventh decade for primary cutaneous melanomas. They are aggressive and resistant to radiation therapy. However, the prognosis is better than with the cutaneous melanomas metastatic to the central nervous system. Now we'll be moving on to part 2 with germ cell tumors of the central nervous system. So these are a family of morphologically and immunophenotypic homologs of germ cell tumors of the gonads and other sites. 80 to 90% occur in the midline, usually in the suprasellar, plus or minus the pineal region, and simultaneously suprasellar and pineal region lesions diagnostic of a germ cell tumor. These are called the synchronous germ cell tumors, which comprise of 13% of all germ cell tumors. They are highly sensitive to radiation therapy, and predominantly in males, they are in the pineal region, and in females, they occur more commonly in the suprasellar region. Aside from benign teratomas, all intracranial germ cell tumors are malignant and they metastasize via CSF and systemically. So the epidemiology of these germ cell tumors of the CNS are they primarily affect children and adolescents, and they comprise of 2 to 3% of primary intracranial tumors, with a prevalence appearance higher in the Eastern Asia, a peak incidence of age 10 to 14 years, and it affects males more than females, although in the suprasellar region, in girls are more prevalent. So CSF tumor markers. Just to touch a little bit on beta-HCG, alpha-fetoprotein, and placental alkaline phosphatase. So germ cell tumors can, but not always, give rise to tumor markers in the CSF. In the case of beta human chorionic gonadotrophin, elevated CSF levels are classically associated with choriocarcinomas, but they can also occur in up to 50% of germanomas, which are more common. Alpha-fetoprotein is elevated with yolk sac tumors, embryonal carcinoma, and occasionally with teratomas. And placental alkaline phosphatase may be elevated in serum or CSF with intracranial germanomas. Important to note, though, is that tumor markers alone are no longer considered useful for making definitive diagnosis or for following response to treatment with a pineal region tumor, since many of these tumors are mixed cell type and many pineal region tumors do not give rise to markers. So the hierarchy of germ cell tumors we would go through in this presentation: germanomas, non-germanomatous germ cell tumors, mixed germ cell tumors. So germanomas, they are malignant tumors of primitive germ cells that occur in the gonads, called testicular seminomas in males and dish germanomas in females, or in the central nervous system. Survival with these is much better than with non-germanomatous tumors, and the variant is the syncytiotrophoblastic giant cell variant. With non-germanomatous germ cell tumors, they include the embryonal carcinomas, choriocarcinomas, yolk sac tumors, which are also known as endodermal sinus tumors, which are usually malignant, and teratomas, which is a germ cell tumor composed of at least 2 or 3 germ cell layers, the ectoderm, endoderm, or mesoderm, and there are subclassifications of teratomas: mature teratomas, which are adult-type tissue elements and minimal mitosis and involve all 3 skin layers; immature teratomas, which contain immature embryonic or fetal tissue alone, or in combination with mature tissue; and teratomas with somatic type malignancy they contain a component resulting from malignant transformation or somatic tissue, usually a carcinoma or a sarcoma. And then there are the mixed germ cell tumors, which we would go through. So mature teratomas, they exclusively comprise of the mature somatic tissue consisting of 2 or more of the 3 skin layers, the endoderm, the glands lined with the respiratory or enteric epithelia. They are often as dilated cysts and are typical and rarely GI and bronchial structures and hepatic or pancreatic tissue. With mesoderm, the smooth and striated muscle, cartilage, and bone, and ectoderm would involve the epidermis, skin appendage organs such as the sweat glands, hair follicles, often with hair, and CNS tissue, choroid plexus, and salivary glands. They have little or no mitotic activity, and their Ki67 in the mature tissue may be unexpectedly high. So the diagnostic criteria for mature teratomas with the central part would be a germ cell tumor with components exhibiting differentiation along at least two of the three somatic tissue lines, and fully differentiated adult type histology with absence of fetal type elements and the absence of other germ cell components. Moving on to immature teratomas, the presence of any incompletely differentiated or fetal-like tissue requires the tumor to be designed as an immature teratoma. The hypercellular stromal elements resembling fetal gut and respiratory tissue with increased mitotic activity are common, and other unusual components may include primitive retinal tissue or neural tube elements. So the diagnostic criteria for immature teratomas are essential would be identification of incompletely differentiated elements exhibiting differentiation along at least two of the three somatic tissue lines in a teratoma, or the identification of any such elements within a tumor otherwise qualifying as a mature teratoma, and the absence of other germ cell tumor components. So teratomas with somatic type malignancy. Somatic cancers that may occur include rhabdomyosarcomas and undifferentiated sarcomas, adenocarcinomas resembling GI tract lineage, and squamous cell carcinomas. Other rare cancers may also be seen, and the diagnosis of somatic type malignancy should not be made based on a cytologic atypia alone. So the diagnostic criteria for teratomas with somatic type malignancy would include essential identification of a distinct histological component that has the cytological features, architecture, mitotic activity, and disorderly growth pattern expected of a sarcoma, carcinoma, or other defined type of somatic cancer in a mature or an immature teratoma. Moving on to germanomas. These are large, undifferentiated appearing cells resembling the primordial germ cells with ample glycogen-rich clear cytoplasm containing round vesicular and central place nuclei. These cells are arranged in sheets, lobules, or cords with trabeculae. Necrosis is uncommon and mitotic activity is variable. Some may have syncytial trophoblastic giant cells seen on squash or smear preparations, but this alone does not qualify them as a choriocarcinoma. So the diagnostic criteria for germanomas is a germ cell tumor containing a large tumor cell with typical cytological characteristics and nuclear OCT4 and widespread membranous kit, immunoreactivity or the absence of 5-methyl cytosine expression, and the absence of CD30 expression, the absence of AFP expression, and ATG immunoreactivity in the syncytiotrophoblastic giant cells, and the absence of other germ cell tumor components, except the syncytiotrophoblastic giant cells and the specific diagnosis of a germinoma with a syncytiotrophoblastic giant cells. Embryonal carcinomas. These are large epithelioid cells resembling cells of the embryonic germ disk containing vesicular nuclei, macronuclei, and clear to violet cytoplasm. Mitotic activity is often increased, and necrotic areas are common. So the diagnostic criteria for embryonal carcinomas would be a germ cell tumor with a large epithelioid cells and CD30 and OCT4 expression, absent or only focal non-membranous kit expression, the absence of ATG expression and the absence of AFP expression, the absence of other germ cell tumor components. The desirable features would be a cytokeratin expression. Moving on to yolk sac tumors. These were formerly called endodermal sinus tumors. They are primitive appearing epithelial cells that may be associated with loose variable cellular stromal components, and bright eosinophil PS positive particles um, may appear in the cytoplasm of the epithelial cells, but they are not a consistent feature. So the diagnostic criteria for yolk sac tumors is as shown here. Of note, AFP reactivity in the cytoplasm distinguish these tumors from other germ cell tumors, except for yolk sac tumors and possibly the glandular and hepatocellular components of some teratomas. Choriocarcinomas, components of the syncytiotrophoblasts, the selective barrier between maternal and fetal blood in the placenta. They are seen characterized by giant cells that encompass cytotrophoblastic elements. And the diagnostic criteria for choriocarcinomas would include a germ cell tumor with both syncytotrophoblastic and cytotrophoblastic elements, but no other germ cell tumor components. It would have a beta HCG expression and the absence of a KIT expression, the absence of AFP expression, absence or only focal CD30 expression, and the absence of OCT4 expression. And for mixed germ cell tumors, these are combination of germ cell subtypes which exhibit the same findings as the subtypes in pure form. The diagnostic criteria would include a germ cell tumor with at least 2 distinct germ cell tumor subtypes. And this brings me to the end of part 1 of the hematolymphoid tumor. Sorry, and the next part would be on hematolymphoid tumors involving the CNS. Thank you.